check.
Good morning, everybody. Good morning, everybody. My topic is on a survey in current occupational therapy practice for children with autism spectrum disorder. Autism spectrum disorder is a pervasive developmental disability characterized by severe, complex, and permanent behavioral and cognitive disabilities. Children with autism are often reported to show difficulties in their day-to-day performance in self-care, school, and play skills. Occupational therapy is one of the most common services received by children with ASD. International Classification of Functioning Disability and Health, developed by WHO, states that autism experts consider ICF children youth version categories from all areas of biopsychosocial model as relevant in the assessment intervention process with young children with ASD. Comprehensive and brief ICF course sets for ASD was developed with the goal of providing useful standards for research and clinical practice and impairment in ASD in different areas of life and across the life. Even though there are many studies done in Western countries to find the common occupational therapy practices for children with ASD, there is no study done in India regarding this issue. The study is going to find out the current practice of occupational therapy service based on ICF-CY version in India. Aim is to analyze current occupational therapy practice for children with autism spectrum disorder. My objective is to determine current therapy practice, which includes assessments and interventions applied by occupational therapists in the management of children with ASD, and to explore what additional developments are required in this field. My research question is whether occupation-based interventions are focused much than sensory needs for children with autism spectrum disorder in India. I have adopted cross-sectional study. I included occupational therapists practicing in India, currently working with or who had already worked with children with ASD. I have excluded occupational therapists who are working in abroad. My sample size is 76 and I have used a snowball sampling technique. I have used wide web-based survey. The original questionnaire was obtained from my mother's study and with the proper consent of the author, I have modified and made adjustments to make it culture specific. Then I got content validation through 3 pediatric occupational therapy experts, and this modified questionnaire consists of 6 sections which are frame of reference and models of practice, assessments, outcome measures, intervention, adaptive behaviors, professional developmental needs, and demographic information. Data was collected and results were analyzed using descriptive statistics. 98.63% of my participants used sensory integration frames of reference as the most. 82.89% of my participants used model of human occupation as a common model of practice. 42.11% of my participants served age group of children 3 to 5 years for ASD kids. Coming to methods of assessments and outcome measures, more than 85% of my participants indicated that they always performed interviews with parents or caregivers in their assessments. Use of non-standardized assessments. Using interviews or observations were the most commonly used as non-standardized assessments by my participants. Coming to standardized assessments in body structure and function, the most commonly used assessment is sensory processing or sensory integration assessments. In activities of daily living skills assessments were most utilized. In participation, play and leisure assessments were most utilized. In environmental factors, family-related assessments were most utilized, and in In personal factors, enjoyment-based assessments were most utilized. Interventions programs used. According to body structure and function, sensory integration training, which shows a percentage of 73.68, was mostly utilized intervention by the participants. According to activities, floor time techniques, which shows a percentage of 27.63, was always utilized by the participants. According to participation, play therapy, which shows a percentage of 56.58%, was utilized by the participants. According to environmental factors, environmental modification, which shows a percentage of 37.53, was often utilized by the participants. According to personal factors, art therapy, crafts, and games, which shows a percentage of 31.58, was always utilized. The most common short-term OT intervention goal was to manage issues related to sensory difficulties. The most common challenges experienced when working for children with ASD was sensory issues. 65.79% of my participants always used occupational therapy settings in OT intervention. 73.68% of my participants always collaborated with parents or caregivers in OT intervention. 51.32% of my participants showed high level of confidence when working for children with ASD. 59.21% of my participants always worked on school readiness skills in areas of adaptive behavior. 35.53% of my participants have attended sensory integration certification. 28.95% of my participants would like to attend sensory integration workshops in future. 50% of my participants showed high preference in attending multidisciplinary workshops to obtain knowledge and skills. Discussion. This study clarified the current practice patterns for providing occupational therapy services for children with ASD in India. The results shows that the theories, assessments, and interventions used by the participants are mostly associated with or based on sensory integration for children with ASD. The result matched the findings from other studies such as Masney-Kader et al., Rennie-Watling et al., Ashburner et al., and K. Smith and Absman. Currently, young children with autism were much more likely to receive a service in India than older children, adolescents, or adults. Interviews with parents or caregivers of children with ASD reported by the majority of the participants as always being performed in the occupational therapy services for children with ASD. Courses associated with or based on the sensory integration approach was reported as both most attended and would like to be attended by the participants. Collaboration with other professionals was also highly rated as always or often by the participants. With respect to adaptive behaviors in ADL, almost half of the participants indicated that they often addressed school readiness skills, play or leisure participation, social skills in their services. Regarding the method of obtaining skills and knowledge, multidisciplinary workshops were preferred the most by the participants. Here, majority of my findings matches the finding of my mother study. So, according to ICF, body structure and function was mostly focused regarding standardized assessments and interventions or programs used. Compared to other findings, there have been only few changes in evidence-based practice related to selection of theoretical model, assessments, and interventions by the participants in India. Here are my limitations. Due to nature of study, higher response would have been desirable, although was not possible, might have difficulty in interpretations on questions asked. Future research to be undertaken in larger survey for better understanding of the services provided for children with ASD, to find why occupation-based interventions are not focused much, to carry out a research to understand the main focuses of families in managing the daily needs of their children with ASD, to find out why the other components of ICF are not focused rather than focusing on body structure and function. This study concluded that selection of theoretical models, assessments, and interventions are mostly focused on sensory integration and not on occupation-based interventions for children with ASD. Occupation-based approaches to be focused while working for children with ASD. Standardized assessments and interventions to be implemented in all the components of ICF rather focusing only on body structure and function. Here are my references. Thank you.
Thank you for your presentation.
I would like to invite next.
Important announcement: student gold medal day, best graduate gold medal examination is being conducted in the VIP lounge downstairs. All the students appearing for the exams are requested to go there. The delegate IT will be taking place in Abiol, where we had a GB meeting yesterday. All the delegates presenting ITs should be present there. The IOTR examination will also be conducted in the VIP lounge. All the delegates appearing for IOTR examination are directed to the VIP lounge. Thank you.
I would like to invite the second speaker, Dr. Ahirma Agarwal. The title is Utilization of Leisure Assessment and Intervention by Occupational Therapy Practitioner in India, Cross-Sectional Study.
Good morning, everyone. I, Dr. Agrima Garwar, is here to present my paper titled Utilization of Leisure Assessments and Interventions by Occupational Therapy Practitioners in India, a cross-sectional survey. Introduction. Despite being a key construct of OT models, leisure and its theoretical concepts or practical availability has been limited. The meaning of leisure has been more of subjective experiences by clients and not used as an end goal in the intervention process. Using the leisure could assist occupational therapists in developing competent skills, instigating a sense of freedom, and create opportunities for exploration, socialization, and relaxation. There are many informal assessment techniques such as client interviews, observations, activity analysis, which are used along with questionnaires such as role checklist and modified interest checklist. Although using standardized assessments such as Leisure Diagnostic Battery, Ohio Functional Assessment, or Nottingham Leisure Assessment will guide the practitioners to quantify leisure as a prime occupation, enhancing the engagement of leisure assessments during clinical practice. Interventions based on leisure would assist in reforming the identity, developing emotional intimacy, coping with new lifestyle post-trauma, enhancing quality of life, and guiding through the process of occupational adaptation. Being a valid and valuable occupation, leisure-based studies are pertinent to occupational therapy and have been scarce. Therefore, this study was an effort to shed light on the application of leisure assessments and interventions by OT practitioners in India. If you are losing your leisure, look out, you are losing your soul. Similarly, if OT practitioners are not involving leisure in their routine assessments and interventions, we are losing one of our major occupations. Rationally, Zhong and Park identified the participation and exploration of leisure activities, reduced the level of depression, and improved quality of life in community-dwelling elderly. Similarly, higher performance ability and self-efficacy was achieved in children with neuropsychiatric diagnosis. Leisure adaptation after complex neurological disability assisted in coping with the loss, reframing the identity, and helped in prevention of occupational deprivation. Of all the realms of occupation, leisure has been most undervalued and less acknowledged area with paucity of quality evidences or novel tools and interventions. Therefore, it is an imperative to redirect the focus of OT professionals towards leisure for creating meaningful balance of occupations. Aims and objectives: to identify the prevalence and application of leisure assessments and interventions by OT practitioners in India, and to explore the usage of standardized leisure assessments and its clinical utility. Methodology: an electronic survey-based questionnaire was developed and the experts in the field established the face validity. Experts were chosen based on the criteria of minimum master's degree with at least 10 years of experience. Based on the opinions, the questionnaire was edited and finally sent to the prospective OTs via emails and WhatsApp. All the participants were sent reminder mails for increased participation. The survey included 3 sections: demographics, leisure assessments and interventions, and follow-up responses. Data analysis was conducted using Microsoft Excel. The chi-square test was conducted to determine the association between the demographic factors and the usage of leisure assessments. Study design was a cross-sectional survey, sampling convenient and snowball sampling. Study participants, OTs with minimum bachelor's in occupational therapy, having minimum 1 year of experience from AIOTA recognized colleges. Data collection, data was collected from March 2021 to July 2021 through electronic survey. The formulation of the survey was based on Cherry's checklist. Results, a total of 202 responses were received, of which 68.3% were females and mostly belonged to the age group of 21 to 30 years with minimum at least 0 to 5 years of experience. 97.02% therapists reportedly valued leisure in their practice, but only 85.6% were utilizing leisure assessments through informal methods like clinical interview, clinical observation, and task analysis. And only 11.6% therapists were using formal leisure assessments in their practice, of which COPM, role checklist, and modified interest checklist were the most frequently used scales. This is the table of demographic data of the respondents included in the survey. This is the depiction of the formal leisure assessments that were used by Indian OT practitioners, and as we can see, some of the major standardized tools such as Leisure Diagnostic Battery, Leisure Competence Measure, Ohio Functional Assessment Battery have been, even are not aware of, many of the therapists are not even aware of these scales. So 49.2% of the therapists reported difficulty in performing standardized leisure assessments in the clinical practice. Most therapists reported following COPME model and model of human occupation to plan the treatment based on leisure activities. Maximum therapists planned leisure-based interventions to motivate and increase the activity participation, and 57.3% involved leisure activity to adapt it as per the client's current skill level. But there were very few therapists who directly intervened for the development of a component skill or leisure as an end goal pursuit. These are the statistical inferences from the chi-square test. There was no significant association found between demographic factors and the usage of leisure assessments. Discussion. The purpose of the study was to have an improved understanding of how Indian OT practitioners apply leisure-based assessments and interventions. Multiple respondents reported maximum usage within pediatrics or developmental disabilities, similar to the results noted in the survey of occupational therapy interventions used in routine practice, revealing that Indian OTs practice mostly among children up to 15 years of age. Only 6.3% respondents were practicing in the area of geriatric care, which was homogeneous to the results of 2014 Health and Retirement Study, signifying older adults did not participate in regular leisure activities, but were involved in passive activities such as watching television. The study signifies the lack of awareness of developed tools to assess leisure. However, there was a new tool that was recently developed, Leisure Activity Participation Scale, utilized to measure the participation in leisure domains. Only 3.1% were aware of this concept of flow, which was utilized during the development of labs and was suggestive of how an individual performs activity matters more than what type of activity is being performed. The limitations of my study were small number of respondents, lack of generalizability, open-ended survey questionnaire, and lack of responses from some parts of the country. Further recommendations to conduct more precise and extensive quality studies with domain-specific clinical areas focusing on the usage of leisure assessments and interventions. Conclusion. The urgency to reallocate the focus of the profession toward its key component leisure is clear and necessary. The use of leisure assessments will assist in exploration of skills and assist in planning leisure-based interventions. More focused, client-centered, and goal-oriented leisure interventions will be beneficial and assist in improving the overall well-being and quality of life for individuals with varied abilities. These are my references. I would conclude my presentation with a quote, "The best intelligence test is what we do with our leisure." Thank you.
Thank you for your presentation. We'd now like to invite the next presenter, Dr. Lakshita Jaya, for a presentation on the job satisfaction analysis in budding occupational therapists working in different setups across India.
Hello. A very good morning to one and all. The title of the study is Job Satisfaction Analysis in Budding Occupational Therapists Working in Different Setups Across India. So, introduction. Very good morning. The title of the study is Job Satisfaction Analysis in Budding Occupational Therapists Working in Different Setups Across India. So, introduction. Job satisfaction is a well-known concept and is defined as the attitude of a worker towards his or her job, often expressed as a pleasurable response of liking and disliking the work itself, the rewards, that is pay, promotions and recognition, or the context, that is working conditions and colleagues. Despite 71 years of existence in India, OT has not been able to gain the required momentum in the healthcare sector. According to data obtained from the AISHE MHRD 2018-19, 502 students pass out the BOT course as compared to 3,454 enrollments every year. In common experience, most of the students drop out of the course or change their stream post the completion of graduation. Of those who continue, more than 25 to 30% of the OTs in India have migrated to overseas countries owing to inadequate lucrative opportunities in both government and private sectors. Many OTs in India believe that individuals belonging to other professionals step into their domain knowingly or unknowingly. International studies carried out regarding job satisfaction among OTs suggest that they tend to be dissatisfied at times with the salary structure, working hours, nature of work, lack of recognition, and respect from the fellow workers, amongst other problems. No such studies have been carried out in the Indian context in the past. The job satisfaction of a worker has a direct impact on the quality of services rendered by OTs in India and thus affecting the overall scope of growth of the profession in the future. So, budding OTs are the future of the country. Understanding this group of professionals is the key to anticipating the needs of future professional workforce. Using various standardized scales to perform the job satisfaction analysis in OTs working across different setups in the country would help us to get a realistic picture to the current scenario of the budding therapists in India and provide an anchorage for the possible opportunities for promotion of the profession in future. So the study design was the online-based cross-sectional survey. The inclusion criteria was presently working OT professionals who had completed their graduation and passed out within last 5 years. The questionnaire was an amalgamation of demographic data, JDI, JIG, TIM, and SIG, that is Job Descriptive Index, Trust in Management, and Stress in General Skills obtained from the Bowling Green State University, Ohio. So the procedure consists of forming the questionnaire. The expert opinion was sought out before giving the final shape to the questionnaire. The data was collected, forms were administered through Google Forms and disseminated through various social networking sites, and data was collected from about 402 participants, 254 females and 148 males, and the data was processed according to the scoring manual as provided by the Bowling Green State University. So the results we had, 63.1% of the female responded to the survey, whereas 36.8% of the males responded to the survey. The population who responded in the age bracket 20 to 25 were 63.1%, followed by people who are in the age bracket 25 to 30 years, and only 7.7% of the respondents were more than 30 years. About 50% of the respondents were working in the urban areas compared to metropolitan areas, which was 30.8%, and rural areas, which was 19.9%. About 50% of the respondents were from the private sector, followed by the government sector, followed by the semi-government sector. About 29% of the 0.8% of the respondents were from the clinics, followed by the private hospital rehabilitation centers, government hospitals and rehabilitation centers, working in other centers. NGO were self-employed and working in school setups. A majority of respondents were working in the pediatric setup, followed by setups which catered mixed population, neuro-rehabilitation setup, hand rehabilitation setup, mental health setup, geriatric care setup, and oncological setup. About 27.6% of the respondents had an annual income of less than 1 lakh, and only 50% of the respondents had an annual income of less than 5 lakh rupees per annum, and it was quite disheartening to see that only 7 to 8% of the respondents had an annual income of more than 5 to 6 lakhs. So for the job satisfaction score percentage, it was maximum in the urban private sector, followed by the urban government sector, followed by the urban semi-government sector, rural government sector, rural private sector, and rural semi-government sector. Again, job satisfaction score was maximum in case of private hospitals and rehabilitation centers, followed by clinics, followed by government hospital and rehabilitation centers, NGO, other setups, people who are self-employed and who are working in the school. Again, the job satisfaction was maximum for the pediatric setup, followed by setups which cater mixed population, followed by neuro rehab setup, geri care setup, mental health setup, and oncological setup. So very similar trends were seen in the trust and management score percentages. And again, a very similar trend was seen in the stress in general score percentages. So conclusion and discussion, although it is a multi-conclusive study, but I have tried to cover the main points, that there is a young OT workforce in the country, majority working in the urban and metropolitan area, mostly in the private organizations, that is private hospital setups and clinics. So the job satisfaction level and the trust in management level was more in the urban and metropolitan areas as compared to rural areas, but at the same time, the stress in general was also more in the urban areas as compared to the rural areas. So we did a detailed review of literature as to what could be the reason of this. And these are the main points. Pollution-free environment, lower cost of living, and higher self-respect in the OTs could be the reason for the lesser stress in general in the rural setups. A sense of isolation, OT is unable to keep up with the latest trend in practice, traveling long distances, lack of continuing education opportunities, and lack of social outlets for leisure amongst OT could be the reason of lesser job satisfaction and trust in management in the rural setups. For the urban setups, a better working environment, better outreach, and modernized equipments could be the reason for increased trust in management and job satisfaction. And the heavy caseload, too many distractions, and comparatively less healthier lifestyle in our environment could be the reason for more stress. A similar result was seen again when we compared between the private and the government setup, that is the job satisfaction and the trust in management level was more, but at the same time the stress in general was comparatively less. Was comparatively more in the private sectors as compared to the government sector. So these could be the possible reason. The higher salary, fulfillment of therapy goals due to channelization, time-based goals, and continuous feedback from the employer in the private setups would lead to a better job satisfaction and trust in management, whereas heavy caseload, pressure to meet targets, frequent overtime, and long working shift and less breaks could be the reason of more stress. Lesser structured working hours, flexibility, and sense of security in the government setup contributed to a lesser stress. Lesser scope for growth and advancement, stagnation, and low financial growth in the government setup was the reason for lesser trust in management. Pediatrics has no doubt become the most popular practice form of OT in India. Therapist working in pediatrics shows maximum job satisfaction and trust in management, but the greatest stress in general. Pediatric OTs share risk to stress in the form of repeated exposure to distress and difficult behavior, prolonged intervention, and uncertain outcomes. Mental health, geriatric care, and oncological rehabilitation are new concepts which will take time to advance. Despite being one of the key areas of practice in OT, very less is known about OT practice in mental health settings in India. Geriatric care is conspicuously missing from the medical education curriculum in India, and the role of OT is unrecognized. Very limited literature is available regarding the oncological rehabilitation by OTs in the country. It is clear that job satisfaction is the least in these fields. It is quite disheartening to see that the average remuneration of majority of the therapists is less than 4 lakh rupees per annum. In a study carried out by Money K et al. Stated that although the average outlook of the profession in the country looks positive and the average salary of a OT has increased over the years, yet multiple professional issues need attention to augment the growth of the profession in the country. The study points out the comparative job satisfaction, TIM and SIG for various setups, discusses about the recent job trends of the budding therapist, but it fails to discuss the possible solutions as to how to improve the working standards and promote the growth of the profession. A solution-oriented study could be carried out in the future. So these are my references. Thank you.
Thank you, Dr. Lakshita. I'd like to invite next speaker, Dr. Yash from Mumbai. The title is Occupational Participation in Patient with Neurosurgical Recovery Unit Using Functional-Based Structure Cognitive Intervention. Case series.
He is awake, but still does not respond when called. It is really disturbing to see an active person like him, dependent even for eating. Will he ever recover and get back to his routine life? These narratives of caregiver of a young patient admitted to neurosurgery ICU aroused curiosity in me and led to this study titled as Occupational Participation in patients from neurosurgical recovery unit using functional-based structured cognitive interventions, a case series. So when we think about neurosurgery ICU, we come across a number of patients with different diagnoses as seen on the screen. The advances of neurosurgical interventions have led to better medical prognosis, but this does not hold true for the functional prognosis. These patients experience a lack of control, reduced sensory stimulation, reduced engagement in meaningful activities, thereby causing occupational deprivation. In addition to physical weakness, risk of developing cognitive impairments leading to long-term cognitive dysfunction and functional decline is also present. Also, limited evidence about early task-specific training carried out by occupational therapists directed towards cognitive and functional engagement within intensive care units was there. So what did we do about it? We designed a functional-based structured cognitive intervention to facilitate early occupational participation in patients admitted in neurosurgery recovery unit. So how did we do it? So following media was used, a comprehensive toolkit comprising of 12 graded, culturally and contextually relevant functional activities were used. It included objects of daily living like toothbrush, comb, pen, lock and key, spoon, glass, pictures of vegetables, fruits, preparing food, activity cards of tasks such as combing hair, drinking water from glass, wiping face, doing namaste, etc. These are pictures of some of the activities that we used. So we delineated 12 skills that were needed for occupational participation and designed 12 graded activities ranging from multisensory stimulation to higher executive functions. So coming to the methodology, this study is a case series. 5 patients admitted to NSRU of tertiary care setup who are medically stable post-intervention were participated. Written consent was taken adhering to Declaration of Helsinki. Following was the inclusion criteria: patients who underwent neurosurgical intervention, who were at risk of developing delirium, disorders of consciousness, cognitive dysfunction, who scored 9 or above on Glasgow Coma scale, both males and females in the age group of 20 to 65, with formal education till primary school or above. Patients who were in vegetative state or critically ill, and also patients who were constrained because of agitative behaviors were excluded. So how did we go about it? So this toolkit was improvised and validated by 4 expert occupational therapists and co-authors. Their suggestions were taken into consideration and activities were modified, following which comprehensive neurological evaluation was done, based on which we found out problem areas in the functional cognition perception. Then we used Pittsburgh Rehabilitation Participation Scale to assess the level of participation. So then coming to the scale, we administered the scale pre-intervention, post-intervention, and during each subsequent session till discharge of the NSRU. So this is a Likert scale where scores range from 1 to 6, with scoring as poor, fair, good, very good, and excellent, and following are the criteria. So this is the way we score each session. Coming to the case studies, patient A was a 62-year-old male who came with aneurysm survived by his son. On evaluation, we found out that he had impaired sustained attention, declarative memory skills, and deficits in problem solving, based on which we gave following activities. So as you can see on the screen, your patient had to categorize pictures for his declarative memory skills. In the second video, he had to copy simple design for problem solving skills. And number 3, we targeted abstraction. So he had to recognize facial expressions and recognize it. Coming to the patient B, who was a 45-year-old female, homemaker by occupation, survived by husband. She had ideomotor apraxia, procedural memory deficits, for which we gave following activities. As you can see in the videos, she had to arrange the sequencing cards which were culturally relevant of eating apple, activities like planting a tree. Here we gave imitation of simple unilateral hand gestures to target her praxis skills. Patient C, a 44-year-old male, driver by occupation, survived by wife. He had decreased arousal level, motor aphasia, unilateral neglect, and impaired sustained attention. So we wanted to improve his GCS score and arousal level. So here, as you can see in the video, we used olfactory stimulation. to increase his arousal level, and you can see the adaptive response in the video. The way he's non-verbally communicating with the therapist. Similarly, these are the demographic details and the cognitive perceptual deficits of patient D. Following activities were given. Following are the details of patient E, and following activities were given. Coming to the result and discussion, all five patients showed improvement in the level of participation post-intervention. However, patients B, C, and E showed significant result, that is change in participation score of 33, 34, and 33% respectively. You can see the trajectory of the level of participation in this graphical representation as well. So as their level of participation improved, the complexity of the task was also increased. We graded the activities depending on their skills. So here, as you can see, the patient's arousal level and GCS score improved, and he could perform these activities. His awareness of environment also improved. So what factors could have led to better functional outcomes in these three patients? Number one, evidence shows that context-specific functional approach, that is when activities include a variety of context and functional domains, clients experience better functional outcome post-cognitive dysfunction. Also, early cognitive intervention improves recovery process and reduces disability as the brain displays heightened sensitivity to rehabilitation in early stages after the lesion. Other factors that could have led to rapid recovery is the pre-morbid active occupational role. So the patients B, C, and E were driver, homemaker, and farmer respectively by occupation. Their family members or the caregivers were actively involved in the therapy process, and given their young age, this could have led to cortical reorganization, that is rapid recovery. Coming to the scope and limitations of the study, this study facilitates setting goals and closely observing patients' occupational participation on day-to-day basis. However, results of this study cannot be generalized due to study design and low sample size. It facilitates clinical reasoning for novice therapists who are just starting out for designing a session and monitoring the outcome. However, evaluating change in neurological deficits of patients was beyond the scope of the current study. Coming to the conclusion, this study highlights the importance of acute care occupational therapy and specifically early cognitive training with post-surgical recovery phase. A structured program, client centricity, and using meaningful activities led to improved occupational participation and early transition to general care ward, and thus improving their quality of life. And this is the magic of occupations. Following are the references that we used for the study. Thank you for all your active attention.
Thank you. So the last presentation, we invite Dr. Naresh Babu for a presentation on the effect of siblings' participation during occupational therapy sessions on the sensory profile among children with autism spectrum disorder and quality of life of their families, a quasi-experimental study.
Morning to all. Yes. So my topic is on effect of siblings participation during occupational therapy sessions, which is SPOT program, on the sensory profile among children with autism spectrum disorder and quality of life of their family, a quasi-experimental study. As an introduction, siblings plays a major role in any family, and they play major in physical, emotional, and cognitive skills development of their needs. And intrinsic development of the relationship and bonding is more important to improvise the children with autism spectrum disorder. Family center services are very limited in our practice, even though we concentrate more on the individual sessions, but we need to focus more on the family center care as well as the top-down approaches. So as an occupational therapist is concerned for the optimal functioning of the family, with special needs, stress can happen response to the care of involved in raising the special need child, and parental and maternal adjustments with special need child is an interactive process. So as a spot program, sibling participation during occupational therapy session is selected, a free fun-filled client-centered activities where the siblings participation both in the group and individual based outcomes. This is a spot program model where we used all these play skills as well as the sensory motor skills and the daily living skills. As a review of literature, we have at least around Indian studies, which is 3, and international studies of 17, where it shows siblings plays a major role in the therapy sessions. But they have not focused on the sensory profile or on the family of quality of life. As my methodology, a study to determine the effect of siblings participation during occupational therapy sessions on the sensory profile among children with autism spectrum disorder and quality of life of their family. So the major objectives are to investigate the effect of siblings spot program on the sensory profile and to find the siblings participation during the quality of life. And the third objective will be to find the association between the severity of sensory issues of children with autism spectrum disorder and the quality of life of families of the children with autism spectrum disorder. So as an hypothesis, null hypothesis is spot program may not be significantly effective on the sensory profile among children with ASD and quality of life of their family. And alternative hypothesis will be significantly effective on the sensory profile and among children with ASD and quality of life of their family. So my materials and methods, this is quasi and experimental study, an independent variable spot program, the therapy sessions. Independent variable is sensory profile as well as the whole brief scale, which is quality of life, and a convenient sampling, and 60 sample size been taken, both 30 in experimental as well as in 30 in control group. As an inclusion criteria, we diagnosed with DSM-4 criteria, and the MCHAT is taken for less than 2 years old, and both male and female will be included. Here, we conducted at a particular center, and the caregiver who were given consent were being taken, and only the blood-related siblings were taken, and living together for more than 4 hours, they are interacting with the children. So only those who have signed for the informed consents been included. Some of them who have not consented later on not been excluded. And parents who concentrated about like having a IVF also been included but kept it hidden. Exclusion criteria, as we have a children with other associated disorders and physical disability will be excluded, and identical and fraternal twins were being excluded. Children who were receiving occupational therapy services at the other centers has not been taken. And broken and divorced family or a widow or a single parent has not been included. The instruments or tools used, Indian Scale for Assessment of Autism, or Modified Checklist for Autism with Toddlers, World Health Organization Quality of Life Scale, which is brief scale, and sensory profile, both toddler as well as the caregiver question has been taken. These are my tools. The procedure, actually the children with autism spectrum disorders receiving institute-based intervention were identified and informed consent were taken. Children will be screened using modified checklist for autism with toddlers for initial screening, even though they were being assigned or referred by a developmental pediatrician to our center. And 30 children will be allocated in the control group and 30 children will be allocated in the experimental group. Actually, it is convenient. Both sensory profile 2 and whole brief scale will be taken pre and post. This is a procedure for 8 weeks intervention, and institution where actually first initial 25 minutes will be given as a conventional occupational therapy with our program. The later 20 minutes we have a 45 minutes, so last 20 minutes will be involving the siblings inside the sessions. So here the spot program will be 20 minutes at the later half of the session. The siblings will be allowed to participate only after the part. And all consent forms and siblings' interest and the school authority permissions has been taken priorly to participate in the study. All will be consented for the 2-month package. Actually, it is a commercial center. So regular attendance will be included in the study. And during the pre and post, whole brief scale will be noted and discussed with the caregiver's parents. This is my master chart. The results, actually the total 60 patients clients were participated in the study, all of them are accounted for the study results, as there were dropouts in the study, but they were not actually given the informed consent. Then the baseline demographic data were being analyzed for the group homogeneously and results are prescribed in the table, as we have both the demographic data from age group being taken from 2 to 6 years. So we have compared within the non-parametric test of both Wilcoxon and the Mann-Whitney's test. We scored good improvement in both the groups, in Mann-Whitney as well as in the Wilcoxon. And the association between the proportional of sensory profile improvement as well as on the whole brief scale. We can able to see the directly proportional between the both the scales. And these are my results, which showed little improvement in both sensory profile and quality of life of the scale. Where actually sensory issues reduced, it can improvise on the quality of life of the family when the siblings been involved in our sessions. The uniqueness of the current study is there are many studies on the language as well as on the social communication, but socialization and cognitive capacities, but there were no studies in the past that attested to the sensory profile of the ASD when treated along with the siblings. And in a recent meta-analysis, it was emphasized to research more on the ASD siblings interaction in terms of family interventions and support strategies. As in my discussion, the chosen quasi-experimental design with the convenience sampling technique aimed to investigate the impact of sibling participation during the occupational therapy program on the children with ASD. And the selection criteria were planned keeping the siblings' demographics in mind and ensuring a homogeneous sample of 60 children aged from 2 to 6 years, and with mostly with autism spectrum disorder. The inclusion of siblings with a specific age range and living situations added a layer of control and relevance to the study of objectives. The study utilized well-established outcome measures, the sensory profile 2 and the whole brief, quality of life scale, and these tools will be standardized and scoring systems will be provided. And the limitations, we have some limitations like we have not taken the fraternal twins, and even we have to see about the other schemes which can be able to utilize in the near future. This is my conclusion, as this study has shown the improvement in the quality of life of the family with autism spectrum disorders. These are my references. Thank you.
May I request all the speakers to come on the dais? Okay. Dr. Francina Jose, Dr. Agrima Agarwal, Dr. Lakshita Jaya, Dr. Yash Dedia, and Dr. Naresh Babu. We are inviting questions from the audience now, 2 per speaker. Please restrict yourself to question and not cross-question. Speaker 1, Francina Jose. Any questions for Francina? Any question for Francina?
Good morning, everyone. Myself, Dr. Somil. Francina, I had one small question. The occupational therapists you had selected in your study, did they have any experience bar or something like that, like a fresher or an experienced person?
Mike.
Thank you for your question, sir. So yeah, I have set some criteria. So I have taken occupational therapists with a minimum 1 year of experience and up to the maximum years of experience.
Any other question for her? Okay.
Yeah,
we move on to the, sorry.
Yeah, Francina, I have a question for you. During your limitation of this study, you have mentioned they might be having difficulty in interpreting questions. Don't you think it will have a significant impact on the results which you have obtained?
Thank you for your question, ma'am. Yeah, it's been a very long questionnaire. So my limitation is might be a few questions might for the participants, they might have difficulty in interpretations of few questions, but majority of the questions will be answerable.
Okay, majority of the
We
question
will-
is answerable, but have you explained the questionnaire?
Yes, ma'am.
Okay.
Thank you.
Next speaker, Dr. Agrima Agrawal. Any questions for Agrima? Any questions from the audience? Okay, no questions. Next speaker, Dr. Lakshita Jaya. Any questions for Lakshita? Yeah.
Good morning, myself Yogita. I heard your presentation halfway, so correct me if the question I'm asking I missed in the presentation. When you were concluding your presentation, you mentioned about geriatric population, mental health, pediatric, oncology. What about the other areas of the adult practice? We have musculoskeletal, we have neurology. It's a wide area of practice. So what happens to therapists in those areas? Did you count that?
Thank you for the question, ma'am. I had included neurorehabilitation as well as, instead of musculoskeletal, I had included hand and orthopedic. That was a section in the, that area was covered, ma'am. Yeah.
We'll restrict to only question. Thank you. You may want to connect to the author later. Thank you.
Okay, myself is Punita Solanki from Mumbai. For Agrima,
Lakshita.
Lakshita Jaya, you spoke about the comparison that was saying about private versus government, that in government the negatives were that low salary and against that private was high salary. So I just wanted to know which regions in India you were talking about. Meaning, is it that in government there is low salary and private there is higher salary? And which regions in India?
Ma'am, actually it was a pan-India survey, so whatever results we got in the survey, it was a clear portrayal of that. And when the review of literature was done, mostly the articles that were chosen covered the whole there was no specific region as such. But yes, it is a very, I think, provocative thought, so future research could be done on this, regional studies could be carried out. So thank you, ma'am.
Thank you. Any further clarification needed? Please contact the author later. Next speaker, Dr. Yash Dedia. Any questions?
Hello, myself Shanta from New Delhi. It was really a good study. I just want to ask the diagnosis of your case series. There were 3 patients. You have not mentioned the diagnosis.
Thank you for a question, ma'am. Ma'am, the diagnoses were mentioned in the slides, but still I will elaborate what were the diagnoses. So there were patients of aneurysms, brain tumors, and arteriovenous malformations.
Yeah, I have already introduced myself before. First of all, I would say that Yash Dedia, your presentation was extremely impressive, and meaning at your young budding age, you did such an impressive presentation. Just a question that you had mentioned that these were like few days of evaluation, right? In ICU from day 1 to day 5, meaning had you continued after that, or it was just 5 days analysis?
So ma'am, I'll explain what was the actual trajectory. So after neurosurgical intervention, these patients are admitted to ICU. Once they are medically stable, they are shifted to recovery wards. So in recovery wards, we already give cognitive as well as motor intervention. But in ICU, for the specific period of 5 to 6 days, we focus more on motor part, like preventing contractures, more of preventive approach. So we thought that why shouldn't we start cognitive stimulation right itself in the ICU, so that the transition to the recovery ward becomes very smooth and the patient gets actively participated in the therapy afterwards. Thank you, ma'am.
Good morning. This is Dr. Vijay.
We'll restrict to 2 questions, sir. Sorry, because we are running half an hour late session. Thank you. You can please connect with the author later. Next speaker, Dr. Naresh Babu. I think there is one question online. You can ask one question here. Please give it to ma'am. Deepa ma'am.
Yes, ma'am.
So Dr. Naresh, I have a question. Because you've chosen experimental and control group,
Yes, ma'am.
was there any blinding done? Because I didn't see that in your slides.
No, it is not. It's a convenience sampling because it's a quasi-experimental study where randomization couldn't able to be done because the siblings, we were only included the people with siblings who can able to come for the sessions. So those who are even having the siblings but they couldn't able to bring the siblings to the sessions have not been included.
Okay.
Thank you.
I do have other questions. Probably I'll discuss with you during tea
Sure,
time.
ma'am.
One more question. Not framed. I can take one more question here. Dr. Pratibha Vaid.
I'm Pratibha Vaidya from Mumbai, TNMC.
Thank
One question, in fact, I would talk about the nomenclature. There is no improvement on sensory profile, but there is improvement in sensory processing disorders.
Yes, ma'am.
Which you are doing it on, you are seeing it with using sensory profile. So whole of your study you are saying spot program and improvement on sensory profile.
No, ma'am. Both conventional occupational therapy as well as the spot program being included. I was saying about the sensory processing only, but there is an improvement in the particular areas like their sensory processing areas, mostly on that. When there is an improvement, they are automatically reflected on their quality of
But
life.
that is your outcome measure.
Ma'am,
That is not
please,
your...
ma'am,
Thank
please
you.
restrict
Thank you.
to one question. Thank you. Yeah. With that, we come to the conclusion of the session. Thank you for the authors.
I request the chairpersons to kindly give the participants their certificate.
I request both the chairs to please give concluding remarks for the session.
I would like to appreciate all the speakers, so well presented. I appreciate all the speakers. We observe some of the lacunae. So the first speaker, the autism spectrum disorder. Usually the diagnosis will be done at the age of 3. But the two speakers, they mentioned the diagnosis age is 2 to 9. Then most of the speakers, they developed some questionnaire, but the validation and reliability process not done. So then the third one is the last presentation. It is like the research proposal. So will be done. This is the already conducted the study. So next one is the rationale. When you presenting any protocol, so you have to explain about what are the rationale behind the protocol. Then most of the studies the quantitative aspect. Why you didn't explore the qualitative analysis? The sample size is very less. So my request to all the budding occupational therapists, you can choose the appropriate research design as well as the sampling technique. Then another one is the variable. The fifth presentation, they use questionnaire as the variable. The dependent variable is the skills, not questionnaire. So sensory profile as well as the brief. That is questionnaire to assess some skill. So likewise, lot of lacunae in ourselves. So before conducting any research, the methodology part is very important. That is a lot of lacunae. So I request all the occupational therapists to improve that skill, but I appreciate all for your effort.
Thank you. So thank you for each of your presentations. To add to what's already being said, I just wanted to, recognize that the strength that came out of all of the presentations was that it was informed by what you were seeing in practice. And especially, you know, the quotes from the patients, I think, Dr. Yash, that you referred to, were really powerful in explaining why the studies were needed. But also to echo the comments around the small sample sizes and to encourage everyone to consider using qualitative research methods to perhaps augment what is being done, but perhaps as a primary method for the studies as well. And then one other comment is just that it seems like with some of the studies that, you know, for example, with the one with the children, identified that most of the children with autism spectrum disorders were being seen and the older children were not being seen, adults not being seen. And similarly with the study, Dr. Naresh, when you spoke about the exclusion of families that perhaps were widowed or divorced or single parent families, you know, some of our assumptions about why we're excluding people or the recommendations about where the services are lacking, some focus on those areas and not only to focus on where the majority of the needs are. But well done overall. Thank you.
I request the chairpersons to kindly give the certificates to the participant. Agrima Agarwal. Lakshita Jaya. Yash Dedia. Dr. Naresh Babu. I invite Dr. Sriharsh Jagidar to kindly felicitate the chairperson, Roshan Galvan. And I invite Dr. Kavita Mahamankar to kindly felicitate the chairperson, Dr. U. Ganapati Shankar.